Good evening, everyone, and welcome to our webinar, Advanced Application and Interpretation of OCT and OCT Angiography in Clinical Practice. We have tonight very interesting topics presented by renowned ophthalmologists. The moderator and speaker for this evening is Professor Aslam. But before I give him the word, I would like to introduce him myself. Professor Aslam began his medical training at Oxford University and completed his medical retinal fellowship at Moorfields Eye Hospital. His current research explores many clinical interests in retina, including psychological aspects and the potential for computerized and technological enhancement of patient care, including novel device development. Professor Aslam is also a consultant ophthalmologist at Manchester Eye Hospital. So, Professor Aslam, the floor is yours.
Thank you very much, Ori, and I'm delighted to see so many people registering for this. I believe we have over 600 people registering and hundreds of people already attending. So I'm delighted to virtually acknowledge your presence, and it's a shame I can't, in this day and age, see you all face to face. But what I can guarantee is that I've seen all the talks today, and there are some absolutely amazing images and presentations, and so you will not be disappointed. I think it's testament that so many people have attended to the importance we all see now in imaging and of keeping up to date with technologies. And I guarantee that by the end of this seminar, you will be feeling that you've learned things today that you'll be able to put into practice immediately that will help you with your clinical care. We're starting off with a talk by Dr. Sal Rassam, who works in the Panacea Medical Centre in Worthing, UK. Sal, I've not visited you there, but the Panacea Centre sounds really, really nice. I think we need to rename our hospital something like that. Sal is an expert in retinal disease and particularly in vascular diseases. And he's going to be talking to us today about OCTA and AMD. So take it away, Sal, and I look forward to seeing your presentation.
Okay, well, good evening, everybody, or good afternoon, or even good morning, depending where you are in the world. That's me. And before I start really to go into the bowels and the intricacies of choroidal neovascularization, what I'd really like to highlight initially is the features and how to optimize the Canon OCTA1 to really get the maximum out of your images. So the ultimate, when you get a new car, the first thing you want to do, you want to know every single switch, every single button, and every single gear and what it does in order to be able to maximize the use of the car and enjoy it. Well, consider this is yet another car you're driving. So you have to understand how the machine works. You want to set it up to obtain the highest possible resolution, the image size that you need to fit for purpose, at the minimum time, so the fastest possible. And that way you will get your maximum patient's cooperation. So I will show you later on how to get into the examination settings, but at the acquisition settings, you can set virtually 5 parameters. The scan pattern, which is actually the number of B scans in any particular grid, and the scan size, which is the size of the image that you want to overlay onto the retina. And these two will determine the distance of B scans and hence really give you finer resolution and finer definition. And these also will determine the time it takes for the B scan to acquire, as well as the number of B scan repetitions. As you know, in order to produce an OCTA image, you really do need a minimum of 2 repeat images at any one particular point in order to show flow. But you can set it up anywhere between 2 and 10 repetitions. But obviously, the more repetitions, the higher, the better the resolution. but it takes a hell of a long time to do 10 repetitions in one go. And I tell you, not many patients are able to withstand that. So apart from these, I'll come to these in a minute. Apart from these, you have your fixation pattern, which determine which part of the posterior pole you want to image, and the C gate, which is the point of focus of the B scan, which is either normal, that is focused onto the inner aspect of the retina, or inverse, which is on the outer aspect of the retina or the choroid. So you can set these up according to how you want it, but you have to understand what each of these parameters is able to do. So if we want to minimize the amount of time in getting the maximum, the best images possible, and I've done a study here where we run the grid scan size as well as the number of scans. So the more the scans, the higher resolution, but the larger the image, the lower the resolution. So you get that sort of number pattern of the distance between the individual B scans in any one particular area. And obviously, the smaller, the better. That's the higher resolution. So you want to achieve the maximum. So really, you want to take a large number of scans in order to be able to do a larger field, but don't use too large a field and don't use too few scans. So this gives you a defined process of how to really pick your right settings. So we have come up at Panacea with these 3 group settings, depending on which part of the retina you're imaging. Don't bother writing these down very quickly. I'm happy to share the slide with anybody if you email me later. The other thing you need to set is your retinal layers. As you know, traditionally, the retinal layers were divided into traditionally superficial, deep vascular plexus, and then you go out into the outer retina, pigment epithelium, and the choroid capillaris. But since David Wang published this article in 2017, he was able to redefine these particular plexuses or layers into sublayers. So you have the radial peripapillary as well as the true superficial vascular plexus. And in the traditional deep vascular plexus, he found 2 distinct circulation, which is intermediate and deep. Now, these layers are not programmed automatically on the OCTA machine when you receive it from the manufacturer. You have to go in and set it up yourself. So in order to do that, you go into the examination settings and you can go into the layer segmentation and you can create as many of these layers as you want by changing these various parameters. This is a short video to show you how to get into the examination settings. So you press on the initial settings rather than entering the mode examination settings. And here you have the various modalities. Where you're interested in is the OCTA. And you can create as many of these acquisition modes as you want according to the different 5 parameters that I mentioned earlier on. Okay. And then at the bottom there where you can define your layer segmentations. So we have created these particular segmentations to show the peripapillary, the superficial, the intermediate highlights, and as well as other layers, which we'll see later on in the talk. Okay, let's go now into the true neovascularization process. And now we have set up our machine, how we can utilize the machine maximum view to get the best definition and to allow you for proper diagnosis. So to me, we have set it up into, well, this comes automatically with the machine, which is choroidal neovascular network layering, which is a total sum of all the layers that potentially can be involved in the neovascular process. And then we subdivide it into 2 areas, which is the RPE and the choroid capillaris. Now this will help us to delineate and stage the disease. So the traditional classification, and which has very much been allowed by the OCTA technology, instead of traditional occult and classic, it's been retyped to type 1, type 2, and type 3. And I'll give you examples of each of these ones. Polypoidal choroidal vasculopathy is considered to be a variant of the type 1 disease. So let's start with the type 1. And you have the classical pathology that patient present with, and you can see that on OCT angiography. And then when you go to the different retinal layers, above the RPE, you do not see any vascularization. Instead, you see a reduction in the reflective ability of the RPE, which really represent damage or sick RPE. You go to the sub-RPE layer, there you have your neovascular process, and then which extends into the choroid capillaris and into the choroid. I find progression analysis very useful in my busy clinic, because when a patient comes, I just highlight today's scans and then retrieve all the previous scans, and I can actually monitor the progression of the disease and the response to treatment. I also quite frequently use the density analysis because it's able to detect high flow and low flow. So high flow shows up as red, and when you have high flow, you have active disease. When you have low flow, then you have regression. 3D is also quite useful tool. Not many people believe in it, but I truly believe in it. And the idea behind 3D is not to twist around the image just to be proud of showing some new technology you have in your clinic. But actually, it's quite useful because you can switch off each individual layer one by one, and you can see the pathology, you can highlight it, and then you can see it in different modalities. And if the patient is sitting right beside you, you know what? The patient love you for that, because it will really impress them, and it also give them an idea of what's happening in their eyes. The polypoidal choroidal vasculopathy used to be thought that you cannot possibly see them in OCTA when we first started using it. But this paper in 2016 was published, which looked at OCTA and compared it with ICG angiography, and they clearly were able to define the polypoidal lesions, and they actually gave it a detection rate of 100% at that time. That was in 2016, and since then there has been multitude of different publications on PCV, and it has therefore been identified that it presents two types of vascular anomalies. You have the branching vascular pattern network and the polypoidal lesions, and accordingly it's been classified into type 1, where you have as well as the polyps, you have the branching vascular pattern, or type 2, where you don't see any branching vessels, just the pure polyps. OCT findings can be quite variable. So apart from the traditional images we see, including subretinal fluid, subretinal hemorrhage, PED, but the particular points that I want to highlight here in PCV is that you get these PED peaks or notches. You get a double layer sign, which is really represents splitting of the RPE from the Bruch's membrane or between the Bruch's membrane and the choroid capillaris. The choroid is often very thick and edematous, and that's termed pachychoroid. And the en face OCT shows you a particular characteristic sign called the RPE rings, which I'll show you later. On OCTA, you can then look at the branch, looking for the branching vascular pattern with the polyps in the periphery usually. And these polyps becomes more obvious as the lesion become progressive and mature. And the detection in all these papers, the detection rate has been classified as between 72% and 100%. So that's really damn good pickup rate for PCV. So this is a typical, this is a patient of mine actually who presented with all the usual symptoms. And on OCT, I want to highlight these particular features. So you have the typical subretinal fluid, you have the PED there. But the double layer sign where the splitting between the RPE and the Bruch's membrane, you can see that there. You have the PED peaks, which represents where these polypoidal lesions are sitting under the RPE and pushing them up. You have the thickened choroid, which is the pachychoroid. And here on the right, you have the OCT, en face OCT, where you can see little rings of RPE defects. And this is the RPE rings that's been defined. On OCTA, you can then look for these branching vascular network and the polypoids. And the polypoidal lesion is usually in the periphery of this branching vascular network. And here, this is the level of the under the RPE, which extends further into the choroid capillaris. These are a series of images overlaid on each other, looking, passing through from the above the RPE and slowly and gradually progressing into the choroid. And it's quite a nice way of looking at where the vascular network arises or when it comes. And you can see where the ring highlights, that's your polypoidal lesions are sitting there. This is done on PowerPoint, so that does not come with your machine. There's another feature in the Canon OCTA. One is that you can overlay the OCT angiography with its corresponding unfast OCT. And you can use this unfast imaging overlay button or bar, and you can go between one image to the other. And here you clearly see where these RPE rings are and where they are in relation to the polypoidal lesions. Very nice feature. Well done, Canon. Again, you can use the density analysis here to show where there is high flow, and that brings up your polypoidal lesions quite nicely. This is the other eye of the same patient. This patient was not aware that her vision is getting worse in this eye, and clearly shows that she's also got a polypoidal lesion brewing in this eye. Again, 3D is my favorite, and by just literally switching off the individual layers, you zoom onto then slowly and gradually the polypoidal lesions, and voila, there it is. It's quite nice. The patient sitting beside you, you can explain to them what we mean by saying polypoidal vasculopathy and how you're going to treat that. Okay, enough of that. We go to the next one, which is the classic, or the type 2 choroidal neovascularization. This is very similar to the type 1, so I'm not going to go through it again and show you examples of these, but the point I want to highlight here really is that if you see this typical, very well delineated vascular network, you could be a bit late, and this disease maybe have progressed quite a bit. Most often when the patient presents to you, and nowadays we're very good at picking up patients at an early stage because of good referral rate and good patients education. And when you see them early, the OCTA, the vascular pattern on OCTA is not always that really terribly obvious. But what you see is little fine meshwork of capillaries, and this is typical of a new lesion just starting to branch out. So there is nothing mature in there. That's really, really nice to see, because we know these are the ones that are going to hopefully respond to the treatment. Type 3 represents the retinal angiomatous proliferation, or RAP in short, and they are defined as intraretinal angiomatous proliferation extending from the deep vascular plexus located in the outer plexiform layer through the outer retina and into defects of the RPE and into the choroid capillaris. Whether they originate from the retina and the choroid, I'll leave you to scour the literature for that, but the thoughts are divided. Certainly John Gass, when he first described it, he described it as originating from the deep vascular plexus, and he classified it into these 3 stages: intraretinal neovascularization involving the choroid or just the choroid. Since then, in fact, John Gass himself has published a series of patients where he showed that these neovascular network start at the choroid and extends into the retina. So at the end of the day, it does not really matter which way it goes. What it matters is how you're going to detect it. And you have to use multimodal imaging, which is very important here in this case. It usually represents itself as a highly reflective mass, and it follows through into the different layers, often associated with retinal features such as CMO or PUD. So this is an example of an early lesion. This patient presents with cystoid macular edema and a stump of highly reflective lesion there. And when you go through the layer of segmentation from the artery and retina, something's going on there. Into the RP, you can see this very fine network of vascular pattern and extends straight into the choroid capillaris. Now, this is a diagnosis. This patient presented in 2016. And in 2016, I had a very primitive Canon OCTA machine, nothing like the one we have today. And I can tell you the AI denoise technology in this current machine is fantastic because it has cleaned up all my old images as well and produced fantastic images. This is the same patient in 2017 after treatment. I'm happy to say that responded to the treatment and the retina is recovering. And as you can see, as the angiomatous closes down and matures, you develop that sort of really well distinct vascular network. Now, what I'd really like to highlight here is not the neovascular process is not always that simple to detect and follow. And sometimes you really have to do a bit of detective work. And the OCT, the Canon OCTA one, gives you the means to do that detective work. So let's go for an example here. This is a PED. We know it's splitting of Brooks membrane, and you can have different forms. The one I'm interested in here is I want to see whether this is a serous drusinoid or there's a neovascularization associated with it. And for that, you rely on the multimodal imaging because both will give you something to look at. So let's go at this example. This is a patient who presents with PED surrounded by a large pool of subretinal fluid. And here you go, the subretinal fluid on SLO, on the large ring, the small ring represent the PED. And when you go to the area involved, and we're using the layer segmentation using the on-fast OCTA, you can see the large area of subretinal fluid and the small area of PED. OCTA, you look at it, you go through the different layers. So the artery, this represents the entire area involved using the CNV layer segmentation, defined layer in your already programmed in your scan, and it shows up the entire area involved. And you're really not quite sure. You can't see really florid vascularization, but I suspect that this is highlighting in this as potential source and potential neovascular network. It certainly is there at the RPE, but it disappears when you go into the choroid capillaris layer. And this is where the OCTA as well as the OCT helps you to delineate that. And there is a little button here called show lines. Go and tick on it, because that will give you two lines. This line is horizontal, and as you move it up and down, it gives you the different corresponding B scan on this in this window. And then the vertical line, you move it until you cross-sect where you think the lesion is, and that will show you the area corresponding to it on the OCT scan. And I suspect that this little elevation here represents the neovascularization process. So this is a video looking at the purely OCT, and it's showing me this neovascular stump. Where is it in relation to the PED and the subretinal fluid? So it's sitting within the subretinal fluid, but smack at the edge of the PED. You can see the PED there, and as the PED disappears, it's sitting at the edge of it. So that really corresponds to the OCTA images. Progression analysis is brilliant, again, because you can see this patient had treatment, and as the patient responds to treatment, this neovascular process highlights more because it becomes more mature. So all these vessels then consolidate, and it loses its fine little capillaries, and you end up with just the big stumps of a dead tree. This is another example where I think it has a neovascular network, but it's not really terribly obvious to me. I can see there is fluid accumulating there, a couple of spots highlighting there and there, but it's not obvious, especially when you look at the OCTAs. You look through the entire territory, you look at the level of the RP, you look at the choroid capillaris. I'm not convinced I can see a CNV there. So that's a bit of detective work here. First of all, you switch on your angiogram. The angiogram highlights in yellow and red dots where there is a flow of blood. And certainly those two areas highlight that there is flow of blood going through them. Then you bring up your OCTA with the OCT, similar to what I've shown you before. You click on the show line tool, and you crisscross your B-scan with the vertical line where you think these highly reflective spots are, and they actually line up exactly where these little prongs are. So this patient has got two very early neovascular networks, one sitting in the middle, and one is sitting at the edge. Fibrotic PD is very interesting. I just thought I'll put that up there because that's really when you end up after treating the patient and the vessels become matured and associated with a lot of fibrosis and scarring. And that's when you see this beautiful vascular network. And that's what most magazines and journals will show you because it's very impressive. But in reality, if you had that at presentation, you missed the lesions too late. Atrophy, I just thought I'll put that in really so as not to mistake it with neovascularization. I'm sure all of you know this. It's just where the RP is atrophied, you can see the underlying choroidal vessels. Now, with the problem with the OCTA technology, be it this machine or other machines, is when you have gross pathology and major disorganization of the retina, they often, or the algorithms for layer segmentations goes haywire, and they lose their interpretation of where the individual layers are. And if they misalign the layers, then that's not going to give you useful OCTA images. So there are two ways of doing correcting this. You can either bring up every single B scan, and if you had 646 B scans, you're going to have to do it in 646 scans, and you edit the layers, you press on the layer, and you bring every single spot and you align it. It's time consuming, don't bother. That's not going to get you anywhere. There's an easier way of doing it. You look at this scan, and you pick one of these layers that the algorithms manage to get it just absolutely spot on, and then duplicate that same line, okay, and move the desynchronize them and move the one line or align the two lines where the area, highlighting the area you want to examine. And that is very good. It'll immediately show you the true layer segmentation and show you the true area of pathology. So really, in summary, I can't really stress enough how important it is for you to understand your machine and you know all the different parameters. Because nothing like getting a really fast acquisition and then an analysis program that will help you in a very busy clinic to get the best resolution images and with the least discomfort to the patient. Don't forget, most of our patients are elderly, they have postural problems, they can't sit by the machine for too long, and therefore you want it as fast as possible. Now, use a combination of all the modalities that comes with your machine. Every single bit will give you some sort of information, and every bit will help you to delineate the pathology. I just want to say that early pathology is not always obvious, and but I've shown you, hopefully shown you the means of really trusting the machine and highlighting the areas responsible. Image enhancement is very good with the Canon OCTA, not only in terms of averaging to get rid of all the artifacts that we used to see in the older machines, but also the artificial intelligence denoise, which is really so good nowadays at smoothing out the images for you. Layer segmentation adjustment is important, as I've shown you, and use every single B scan to search for the pathology. So don't be shy to scroll through every single B scan until you are happy that, well, that's where the pathology is. Progressive analysis or imaging is very useful in a very busy clinic, so I can quickly make a decision on how to treat this patient. 3D imaging is also very useful. to show you the rapid flow through between these layers, and also for patients' education. And density analysis is there for you to use. So in conclusion, we have established long ago that OCTA is a fast and a non-invasive and a very efficient, predictable and repeatable machine. So there's no doubt about that. The detection rate is really quite high, and layer by layer segmentation has really revolutionized the way we define disease process. And the fine details have given us the means to really reclassify disease process. Like any technology, there are still shortcomings. Well, it doesn't give you dynamic studies, layer segmentation errors. But you know what? With multimodalities, I don't think you have a problem in really highlighting the pathology. Thank you.
Thank you very much, Sal, for that. I can see from the slides and the detail and the information you have there, we could easily have gone on for ages more. So we're going to quickly go through now because we're being pushed for time. So we're going to try and cover some of the wide field OCTA imaging, and I'm going to give you a quick introduction. Ola's our research fellow at Manchester Royal Eye Hospital, and we've been working on some of the wide field imaging. Ola's going to talk about wide field imaging in uveitis. I'll let you take it away, Ola. Thank you.
Thank you. Hello, my name is Orla McGrath and I'm a clinical research fellow here in Manchester Royal Eye Hospital. So today my presentation is about wide field OCTA in uveitis. These are some of my colleagues here in Manchester, and I'd like to give a special thank you to Miss Laura Steeples, who helped me with my presentation today. She's a uveitis consultant. So I arrived in Manchester in August 2020 from Waterford, which is in the southeast of Ireland. And since then, I've had the pleasure of using the Canon machine. So OCTA is a non-invasive depth resolution technique, and it adds detailed qualitative and quantitative information of the status of retinal and choroidal blood vessels. The wide field of view allows us to assess the peripheral retina as well as the macula in high resolution, which can also be affected in uveitis. So in February 2021, we published a study in the Journal of Imaging where we had 2 medical retina experts compare the scans of 49 patients pre and post denoise. So they were 10 by 10 millimeter scans, and in 98% of cases, the experts selected the denoised image as best for clinical assessment. No new artifactual error was added and nothing was taken away. So just with the push of a button in less than a second, the images changed from the top to the bottom. So very clear imaging. So OCTA has significantly changed the diagnosis and management for non-infectious and infectious entities. I will run through some imaging of different retinal structures to demonstrate the application of OCTA in different uveitis pathologies. So in uveitis, perhaps the easiest application that we have taken from AMD was the detection and distinguishing between CNV and inflammatory lesions. So on imaging the choriocapillaris, we have found OCTA to help us in understanding the pathogenesis in AMPPE, or acute posterior multifocal placoid pigment epitheliopathy, with choriocapillaris non-perfusion. There was microvascular reperfusion, and it really nicely showed the remodeling in time. So that's this lesion here. You can see the remodeling over time. In stromal choroiditis, OCTA again allows high resolution imaging, and it can be very, very useful in the follow-up of patients who have diseases such as BKH. On viewing the retinal plexus in patients who have intermediate uveitis, flow changes were demonstrated by OCTA in the choroid and in the choriocapillaris and in the GCP as well, or the deep capillary plexus. Microvascular and macrovascular changes in occlusive vasculitis were noted. OCTA allowed automation, quantification. It also really nicely shows secondary neovascularization, and I have some slides that will depict this in a little while. It also shows remodeling and reperfusion. In patients with Behçet's disease, deep capillary plexus non-perfusion has been demonstrated, along with reduced vessel density. So what are some of the uses of wide-field OCTA in our clinics? Well, it allows repeated flow analysis, including quantification of non-perfusion. It also allows the early detection of disease changes and secondary complications. It allows us to analyze if there's disease relapse, including allowing us to look at stromal disease. And we also use it in our diabetic clinics for guiding our laser therapies. There are still some challenges in uveitis with OCTA, for example, small pupils, also say dense vitritis and cataracts. Also, nomenclature and disease-specific patterns are not yet fully established. And also, as we know, OCTA is subject to imaging artifacts. So this was a patient of ours who had primary retinal vasculitis. And so you can see this lens opacity here is obscuring our view on the fundus photo and on the FFA because she had a congenital cataract. But I'll show you the OCTA we had now. So this is her OCTA, and as you can see, the lens opacity is eliminated. You can see this area of vascular shutdown along the supratemporal quadrant of the retina. And just to mention that this is a 17.5 millimeter mosaic view of the retina. So what we did was took 4 10 by 10 millimeter shots of the retina, and we were able to put them together then to give us this nice ultra wide view. So just in comparison to the FFA, this is a multimodal approach with imaging because the OCTA depicts the lack of perfusion, but this shows the leakage, and it's still got a wider field of view even though the OCTA is improving. And this is another case. So this patient was diagnosed with SLE, so severe retinitis, back in 2017. So these images actually predate the wide field OCTA. However, OCTA has been very useful in her follow-up. So this girl, she had severe refractory disease. She required steroids and biological therapy to achieve remission. So she had significant CMO, ischemia, and her disease was subsequently complicated by neovascularization. So this is the OCTA image, and you can see that there is excellent macular flow detail here in comparison to FFA. So it's really, really useful for detailing and monitoring non-perfusion. So you can see all this, the capillary dropout along here, the detail is very good. This is again another 17.5 millimeter mosaic image, which is an optional software on the Canon, and it's very, very quick to put together, just a matter of seconds from 4 shots. And this blue square here, this denotes our field of view of the OCTA. So as you can see, it's really getting wider all the time. This is still the same patient. She went on to develop neovascularization. So you can see how this is the ultra wide field FFA, but you can see here how well the area of neovascularization is shown in the OCTA, and again the areas of dropout. So it's excellent for disease monitoring and for monitoring response to anti-VEGF injections. And so like Dr. Rassam showed us just there, you can put those lines that are on the OCTA just really simply over this area of neovascularization, and you'll see that there's this area on the B-scan, on the corresponding B-scan of high flow. All those yellow dots are flow. So anterior to the retina, there's an area of active neovascularization. This is my last case today. So this is a patient who had Behçet's uveitis, and he had active retinitis in the right eye. So really the run of FFAs was focused on his right eye, whereas when we look to his left eye, you can see that there is leakage, so lots of leakage, and there's that fern type leakage, which is it's characteristic of Behçet's disease. But you can see the capillary dropout, and you can see the atrophy of the macula really, really well in the OCTA. So this is a 10 by 10 millimeter shot, and then this is the DCP, or the deep capillary plexus, and again you can see the severe atrophy here. So to summarize, OCTA is certainly a valuable tool. It has improved our understanding and evaluation in uveitis. It has led to further exploration of specific disease entities and establishing imaging biomarkers for the treatment response, and it's certainly an excellent supplement to our existing modalities. So thank you very much.
Thank you very much, Orla. That was an excellent run through so many beautiful images on uveitis. I did promise you all beautiful images, so we're living up to that so far. I'm going to carry on a little bit and talk about further applications of wide field angiography, in particular vascular causes. And these are my disclosures. This picture always makes me lament what's happened in the last year and a half, because this is where myself and Orla work. And this is a picture taken a year and a half ago, pre-COVID. And now in the waiting room, you see lots and lots of barriers and chairs placed further apart. And the reason I have this is just to say really that a lot of this talk and a lot of my interest in OCTA is based upon the need we have now and in the future going forward on being able to minimize the amount of invasive technologies we use and optimizing each patient visit. We have limited patient visits now in our eye clinic, limited nursing capacity, and so each visit is important to get the best possible imaging in one sitting, and preferably if we can avoid the invasive imaging. So that makes the OCTA even more important. And the images I'm going to show you are just of real patients who came to clinic in the last couple of weeks, to give you an idea of some of the practical uses that we have for the Canon OCTA. So start off with the, the big hitters and the common things of the diabetes. And consensus seems to be now, it has been published, that actually OCTA scanning of diabetic patients should be part of staging and grading. You can see here in this image lots of areas of capillary dropout, and you can get a good idea of macular levels of ischemia and of neovascularization. Possibly those are the key things, but you can also see things like microaneurysms and URMA. And then finally, lots of imaging and research has showed that you actually get differences in density, vascular density. This is a practical example of a patient who came in with diabetes, and they had on clinical examination lots of areas of vessels that looked like vascular abnormalities. We weren't sure at the time if they were URMAs or whether they were neovascularization. There's one particular clump that you can see in this image here that potentially looked like a macroaneurysm, and other areas that might look like URMAs. And just as Orla was saying and Sal was saying, OCTA is really is a sort of dynamic imaging modality. So what we have to do and what we should always do is look at the different levels and the segmentation layers and be able to move them up and down. And at the same time, look at the corresponding B scans. And if you imagine a line going through this knuckle here, and the B scan in the background of this slide demonstrating that, you can see that there's areas of apparent flow. The orange areas in this background B scan image represent flow. So you can see there's an area of high flow corresponding to that knuckle, and you can also see that it's within the internal limiting membrane. So that demonstrates really that this is an area of neovascularization. So it's an area of diabetic retinopathy that requires preventative treatment. Similar uses for OCTA in vein occlusions looking for ischemia. But before we get to that, this is a patient who came just in the last week or so, who'd had a history of potential branch vein occlusion, but currently didn't have any edema on the OCTA, which looked relatively intact, but her acuity was very low. And you can see from this OCTA scan that immediately the explanation for that is very clear, because she has a very abnormal foveal avascular zone with lots of ischemic damage to that area. More commonly, and in keeping with the wide field aspects of this talk, this is an example of a patient with a branch vein occlusion. You can see lots of collateral vessels here and lots of ischemic damage. And actually lots of research studies have been done demonstrating that although we don't get the wider picture of lots of the peripheral ischemia that you would get, for example, in an Optos FFA, if you were able to take a mosaic, and this is a mosaic from our Canon, then in many research studies, what they've shown is that you can detect ischemic disease, ischemic vein occlusions, with a sensitivity, it's reported, of 100%. Essentially, if there's ischemia in these areas, then that's enough to be able to detect that. Possibly it's because of the projection effect peripherally. When you look at an image, it's like when you look at a globe. If you put that onto a piece of paper, all of the areas of the periphery, places like Greenland, suddenly appear massive, but they're not quite as big as they appear. And also there may be some areas of relatively low vascularity in the periphery anyway. But whatever the reason, it does appear that being able to look for ischemia and neovascularization in the wide field mosaic OCTAs is a really good substitute in some ways when you can't have an invasive Optos or wide field OCTA, OCT or fluorescein angiography. Other studies have shown that if you find neovascularization on these areas, then they do have a higher risk of vitreous hemorrhage. So all is in keeping for using this wide field OCTA as a really useful tool for your vein occlusion patients. So those are the biggest areas, obviously, diabetes and vein occlusions, but there are other areas, and these are a couple of patients that we saw in the last couple of weeks. This patient with Coats disease has very obvious abnormal telangiectatic vessels with dilations, aneurysmal dilations in areas of ischemia. And not just with us, but in research studies have shown that this can be quite useful as a technique for monitoring progression of Coats disease, especially in children. And this is the wider field mosaic image. I use OCTA also in CSR patients because with the wide field, sometimes with these external spots of CSR, you can get secondary membranes, and sometimes with chronic CSRs, they have a shallow pigment epithelial detachment, and even with a fluorescein angiogram, it's hard to find and delineate, is that a new membrane or not, whereas it's relatively easy with OCTA to pick up those secondary membranes and ensure that that's not what you're dealing with. So in the last section, I just want to talk about research potential, and I'll be very quick. But just to say that we've done studies looking at OCTAs and shown that it's really useful with some clever machine learning algorithms. We can pick out really sort of very precise diagnostic tools from vascular analysis. And one thing that's great about the Canon is the wide field should gives even more data. It has an automated thing where it can produce a binary image and skeletonized image. That will do some of our work for us actually and produce a more reliable tool for our research studies, where we're hoping to look for the impact of COVID on OCTA images. So thanks again for listening. I hope that you will have from this talk and previous talks some really useful tips for OCTA in the current era and in future for non-invasive imaging. And I'm going to welcome Dr. Parolini now, and I don't give it too long an introduction. I could speak for ages, but she's a fantastic vitreoretinal surgeon from Brescia in Italy with fellowships in the US at San Francisco and Newark. And she's vice president of the European Vitreoretinal Society. She's going to have some great insight for us into myopic disease on OCTA. Thank you.
It is an honor for me to be here with you and present the beauty of wide field imaging in high myopia. First of all, let me remind you what we are talking about. Pathologic myopia is myopia above 8 diopters or axial length of at least 26.5 millimeter. The prevalence of pathologic myopia is 2% of the population, so not so small as a subject. And high myopic eyes are big eyes, as you can see from the MRI of the eye wall. I would say wide eyes. 65% of them have a staphyloma. So you can see in the picture on the left, the shape of a normal ametropic eye. In the middle, the shape of a high myopic eye without a staphyloma, and on your right, a high myopic eye with a staphyloma, which is the ectasia of the scleral wall. You can see in the MRI that the staphyloma can be located in different spots in the eye wall, although the most significant one for us are the posterior staphyloma. Myopic eyes should definitely be studied with wide field imaging, both wide field retinography and wide field OCT. This is a routine 6mm scan. You can say not so significant per se, besides the thinning in the choroid, which is very suspect of high myopia, but it is only the wide scan that shows the presence of the staphyloma in the macular area. Not only, it is the complete study of the eye that reveals that the macula is actually on a slope, and the deepest side of the staphyloma is in the papilla. So only the wide scan and only multiple scan of the same eye can describe in details what we are looking at. The association with the wide field retinography confirms the presence of the staphyloma around the optic nerve. And the ring in the retinography and the arrow on the wide field OCT points at the edges of the staphyloma. This is another example. If you look at the small scan, you can diagnose an epiretinal membrane in a high myopic eye. And you can tell that the 12mm scan can give you enough information to diagnose and manage this eye. There is a epiretinal membrane, and you can see at the papilla what is probably the cortex of the vitreous detached from the macula and attached to the papilla. But it is only the wide field OCT that shows the exact relations between the vitreous and the retina. The vitreous is only partially detached from the retina, and there are special points of adherence that are very useful to know, especially when we go to surgery, because those are spots, especially the adherence to the retinal vessels, as you can see in the bottom left picture. They are at higher risk of a iatrogenic lesion, so it's good to know them in advance. The same patient can be studied with OCTA. In this case, I just want to point out at the direction of the vessels. The right eye shows the tangential traction, and you can see the opposite eye, the left eye of the same patient, is much less myopic and has no epiretinal abnormalities, and the direction of the vessels is completely normal. So a posterior staphyloma is what we can call a scleroconus, as an association with the keratoconus, this ectasia of the sclera that induces a stretching in the retina and in the choroid with different sorts of consequences. So now we will concentrate in the retina. One of the most significant consequences of the scleroconus is myopic traction maculopathy, which is a series of a clinical picture, a wide spectrum of clinical picture, milder clinical picture and more severe clinical pictures that I collected, and recently published this staging system to highlight that this is not just a collection of different types of OCT pictures, but one evolving disease. The staging system is summarized in this single table that shows in the different rows the stages from schisis in the inner layer in stage 1 to schisis in the outer layer in stage 2, schisis and detachment in stage 3, and complete detachment in stage 4. From left to right, you see the evolution in the tangential plane. Stage A describes a normal inner fovea, stage B an inner lamellar hole, and stage C a full thickness macular hole. And each single eye with myopic traction maculopathy presents an evolution in one direction or the other, from top to bottom, from left to right, or in oblique. Even myopic traction maculopathy can be followed with standard length OCT, but much better with wide scan OCT. This is an example of a 12mm scan that shows the schisis and detachment. But with the long scan, we have the whole picture, the design of the staphyloma, and the distribution of the tractions inside the retina. So let's see some stages of myopic traction maculopathy with long scans. This is stage 1, schisis with an intact fovea. Stage 1B, a schisis with a lamellar hole. Stage 1C, a full thickness macular hole. 2A, a schisis with an intact fovea. 2B, schisis with a lamellar macular hole. 3A, schisis and detachment with an intact inner fovea. Stage 3B, schisis and detachment with a lamellar hole. Stage 4A, a complete detachment with an intact fovea. Stage 4B, a complete detachment with an inner lamellar macular hole. And stage 4C, a complete detachment with a full thickness macular hole. We can follow the evolution of MTM. This is one of my patients that switched from stage 2A, look at the schisis, to stage 3A, schisis and detachment, just in a few months. We can also follow the results of treatment. The same table is offered with guidelines of treatment in red. This is the result of a study that I made on a wide series of patients, and I studied which was the treatment that could offer the best result, customized per each stage. So basically, when we have to deal with holes, it is better to do vitrectomy. And when we have to deal with schisis and detachment, it is better to manage with the macular buckle. This is the macular buckle that I use. You see in the video the insertion of the macular buckle in the superotemporal quadrant. This is a model of macular buckle made with a silicone and a titanium stent that bends the buckle as an L or a C. So the indenting part pushes the macula, and you can see through the intraoperative OCT the exact location and the pushing effect of the macular buckle. So this is an example, preoperative stage 3A, meaning schisis and detachment. Vision is very low. These are a few clips from the intervention. I inserted the macular buckle only with the guide of the intraoperative OCT that could show me where I put the buckle and the amount of indentation. And this is the post-op on the bottom right picture, just a couple of months after surgery with a good increase in vision. Again, top and bottom pre-op and post-op after macular buckle surgery for retinal detachment. Again, pre-op and post-op. And I would like you to notice the significant improvement in vision. High myopic eye for surgeons are always eyes that do not improve after surgery, but choosing the right surgery, we can improve the vision of this patient. Look at this patient. It seemed lost, but this is after surgery with vitrectomy, ILM flap, plus macular buckle with a significant improvement in vision. Again, from pre-op, to post-op. I wanted to superimpose the wide scan OCT to the wide field retinography, because only in this way you really understand the anatomy of these patients, from pre-op to post-op, post-buccal surgery, from pre-op to post-op, and again from pre-op to post-op. Is this a buccal effect? No, this is not. This is a dome-shaped macula, naturally buckled and protected from schisis and detachments. So far, I have managed these patients with regular 12mm scans OCT. You can see even here, this is another example, pre-op on top and post-op on the bottom. And yeah, we can do that with a short scan classic OCT. But when I switched from short scan to the wide scan, I understood that I can have much more information, not just in the macular area, but in all the shape of the staphyloma and why some patient evolved in one way or another. This is a lamellar macular hole, so you can tell me why the need of wide scan OCT if the problem is in the fovea. So let me show you this patient. This is a full thickness macular hole. So we just need the fovea scan. I operated with vitrectomy ILM flap to close the hole. And I actually indeed closed the hole, but what happened? The macula detached, and I could not understand why until I studied this patient with the wide field OCT. I could see that he had a deep staphyloma on the nasal side of the papilla, and the type of design of staphyloma induced the macular detachment, although the macular hole was closed. So the reason here was the shape of the scleral eye wall that I could invert after applying a macular buckle. So I really think that high myopia still is a mystery, but with the wide field imaging, we can have more information to be able to help this patient. And I conclude with the new motto that is, let's get wide. Thank you.
Thank you very much. Those are absolutely beautiful images, and thank you for getting through. I know I didn't leave you with much time, so thank you very much for that. I'm really pleased to see advances for our myopic patients, because like you, I sometimes, really regret some of the sort of degenerations they have and things we can't do. I've got like hundreds of questions for you, but I guess the key one is, have you noticed that since imaging has improved, that you've been able to improve the outcomes for the surgery based on the newer modalities of imaging?
Actually, having the shape of the staphyloma, I could improve, yes, I'm using macular buckle, so I could improve the location of the buckle, the how to manage the new shape of the eye and trying to improve the post-op result.
With the intraoperative OCT, is that?
The intraoperative OCT is extremely useful in this type of surgery. You can do it even without, but if you have it, you're more precise and you know where you locate the buckle exactly.
And the other question I had was, with staging and sort of assessment of dome-shaped macula, people often talk about the axis that you look at it, that you should look at the vertical as well as the horizontal. Is there any sort of similar, go on.
Yeah, no, I was about, this is a very important topic. With high myopic eye, you have to study many shapes, not just horizontal and vertical. You need to have them all because every eye has a different shape. Not a single them is standardized. So the beauty of having the wide scan is also to be able to reconstruct the shape and to know how to apply a new shape with your treatment.
Yeah, so the reconstructions you showed were beautiful demonstrations of that. Thank you. And Sal, one thing that I was itching from your talk, it was a great summary of AMD. Can I ask you, in your own practice for IPCV in particular, I know there's there's a variation in literature about whether you can throw away the ICG machine for assessing polyps. Do you what is your procedure now, and how do you manage your AMD patients? What scans do you give them, for example, routinely?
Well, I think really for PCV, most of the time you can. Sometimes it's difficult, I grant you, especially if the patient presents early in the disease process. The polyps are not always visible, and it's only later on after the treatment is given, usually in the form of anti-VEGF, is when these polyps be really highlight and start showing. And in practice, we don't do ICGs. In fact, I don't have even the technology to do ICG. I can do fluoresceins, but I cannot do ICGs. So I rely very much on the OCTA technology. Nowadays, it's accepted that the initial treatment for PCV is anti-VEGF, and it's only if they don't respond, then you can try something like photodynamic therapy. So usually the PCV, if it's not present at the beginning, you give a series of anti-VEGF, and with your serial OCTAs, the polyps will just highlight. And if the patient is responding, brilliant, fantastic. If the patient is not responding, then you know what to do next. So it's really, I rely very much on practicality rather than actually academically looking for the PCV.
Perfect. There is a question for us on measuring choroidal thickness. I guess if we're talking about PCVs, do you have any, do you do that routinely, Sal, measuring choroidal thickness? And the question is, which scan do you measure choroidal thickness?
You can, if you use the inverse Seagate, it gives you a very good definition of the choroid. Even with the OCTA one, you don't need the swept source really to look at the choroid. And you do have a feature in the OCTA one where you can actually measure, calculate or measure the actual thickness of the choroid there. So nothing to stop you from doing that, which is quite useful really in these cases, and you know whether it's responded or not.
Perfect. Well, we've gone a little bit over time, so apologies to everybody for that. But I found lots of really, really useful things in all the presentations, and I think this is a field that's just going to grow from strength to strength. We've covered, very specific topics in OCTA, but since its emergence, we can see that its role has just become massive, hasn't it? Getting wider and wider. I think it's set to become even greater as time goes on. So I think hopefully for the audience there, we've demonstrated some of the uses of OCTA, and you can imagine that this will just expand as time goes on. So thank you very much for everybody for attending. Thank you especially for the speakers for the fantastic talks, and I hope everybody has a good evening.
Thank you.
Thank you very much.
Thank you.